All right, we are live.
All right, we are live on YouTube, and I'll call to order the December meeting of the Health Insurance Committee. President is myself, Tom Walsh, and Jerry Hicks. We have a number of board members on WebEx. If you could identify yourselves.
Tom Green.
Okay, Mr. Green, thank you.
Kendra Cotton.
Kendra, thank you. Brian, are you still online?
Yeah, sure.
Okay, Mr. Dokes?
And then there are others.
And we have others showing up as being online. If you could identify yourself.
Mike Wojcik from Fort.
Mike, thank you.
Beth Ishmael from Horton.
Thank you, Beth.
Okay, I think that's it so far. Yes, we're good.
Okay, everyone is here and present. Mike, if you want to start your presentation, we'll do the bills and minute approval after you finish.
Okay, thank you very much, Chairman. Happy holidays, everyone, and thank you for allowing me to be virtual today. The reports that we posted include the aggregate report, which is the financial report. It would be titled Aggregate Report, November 2020. Before I go into that, get my nice call for healthcare updates, federal and state. There's nothing really to report that's eminent right now, but we do anticipate with an administration change that there will be a lot of discussion around healthcare that we are watching and following both from a federal side, from a state side. What we are also following, I may have mentioned a month or two ago, there is a strong interest in an expansion of Medicaid buy-in option by our governor. And he is taking feedback on that and doing a feasibility study right now, which we are also participating in for a February meeting. So we will keep the county informed of these advances and what type of impact, if any, they will have on our health. Looking at the financial report, the aggregate, on the usual page, we take a look at the average enrollment of our count. Our people count very much this year. The year-to-date 2020 employee count, and this included the retirees post 65, were 656. Last year at the time, they were 654. Our member count went down slightly. I call these belly buttons, which is employees, spouses, and children. It went down 53 in count, slight change. So possibly some singles coming on rather than families onto your plan. Our spend year-to-date through November is almost identical to last year. So 8,936 last year was 8,873, a difference of 0.7%, which is very good. When we look at, if you move further down by yellow in the report, we take a look at the percent of expected cost. And if you recall, each year we forecast and actuarially determine an expected spend from which premiums are calculated from. And you're running about 95.7% expected, which is good. I mean, not spend. Last month it was a little over 96, closer to 97, so we've come down a little bit from last month. While we're on the line, the 2020 actual year-to-date per capita, 14,858. And the member per capita, 8,132 for 2020. That, again, very much in line with 2019. And if you look a little bit further towards the bottom of the page, benchmarks from Tiger State and local government and Mercer were spot on. So a good plan year so far. We got one more month to go. I will focus you on the large claimant category next, and that's the big blue box in the center. And we track large claimants greater than $75,000, we call it. You recall your plan has a specific stop loss protection on it of $125,000. So this year, we actually have more claimants in that category of 75,000. Even though the plan spend has run very well, our large claimants make up a very big portion of it, and had they not been as many in number, the plan year would have been better yet. This year, we had 18 large claimants through November compared to 11 last year. Although last year, as we ended up, by the time we finished, we had 18 large claimants as well. Of those large claimants, just some stats that we take a look at. 9 of them are retirees under the age of 65. 9 of them, not necessarily retirees, are spouses. 2 are dependent children. And we have 9 in the category of cancer. So those have added up quite a bit. The ER responsibility, as you'll see in that big blue box, this year we're running about $1.9 million year to date. Last year at this time we were at $1.186 million, but we did end up with $1.9 million by the end of the year. So last year we had an active December, and this year let's hope we maybe have it all in-house through November. Any questions on that?
No questions from members present. Anyone online have a question for Mike? Nothing heard.
Okay, thank you. The next exhibit would be the pharmacy key indicators report, which we take a look at monthly. I mentioned last month, I did a little research on this, so, and I've got more forthcoming. So next month, when we do our year-end review, we'll have a full pharmacy report. We saw a little bit of a split in the generic dispensing rate. So right now through January, if we go mid-penny, you'll see a category that says generic dispensing rate. November 2020, 82.6. January 19 through November 19 is 87%, and January 2020 through November 2020, 85.6. Kind of was curious as to why we're getting a little bit of a drop in pharmacy in the generic category. And I was reminded that when we changed the formulary list, we went to what's called a performance drug list. And what that drug list determines is the most cost effective and the best efficacy, the best performance drugs for your members. And what that means basically is there are sometimes generic drugs that cost more than name brand drugs. And so the plan automatically will switch it to the name brand drug. And one case in point is Adderall. Is more expensive, the generic version of Adderall is more expensive than the brand version. So the member gets brand. So that's we asked for a full report on these to see what other categories or what other drugs losing ground in that flex switch. On the second page of that pharmacy report is the pie chart that shows, basically on the bottom, where the specialty drugs are. And I forgot to mention on the first page, specialty drugs account for 1.1% of your spend of pharmacy. So, I'm sorry, 1.1% of the scripts, but actually 44.5% of the pharmacy spend. And then now moving to the pie chart page, it shows that we have 16 members, and again, if you recall, this fluctuates. People on these drugs aren't necessarily on specialty drugs continuously, although there are some categories like autoimmune categories that are pretty much chronic. There are a total of 16 specialty claimants that account for 44% of your pharmacy spend. Total of $658,000 year to date. The good news is we are seeing biosimilar alternative specialty drugs coming in the category of autoimmune over the next year. So we should see some relief for those categories. Any questions on the pharmacy?
Yes, Mr. Hicks has a question.
Mike, back to the first page of the pharmacy key indicators. Underneath the generic dispensing rate, then you've got the formulary compliance, and there's a generic substitution rate. I guess when I look at that, I would think we're doing phenomenal because we're going 98.3% in the area of trying to get generics prescribed. Is that a proper way of looking at that, or do you have other explanation?
Yeah, no, that's very good. And again, it's per that comment I made that the performance formulary, and even equally as important category is the formulary compliance rate of 99.5%. That, when we made the formulary change about a year and a half ago, we were running at about 92, 93%. To get that close to 100 has really saved the plan a lot of money and not compromise the members at all.
I think it's very commendable on that.
So, I'm sorry?
I think it's very commendable that things are moving in that direction.
Yeah, absolutely. Absolutely. And it's, again, great work to your team, great kudos to your team for adopting these things and to your members for complying with that. The generic substitution is also very good, as you mentioned, Mr. Hicks. The 98.5. This is one that's going to teeter a little bit because of what I just said earlier, that there are actually some name brand drugs that are less expensive in cost than some generics. But the plan is doing that automatically for you. So in our full report next month, I'll try to have a little more detail into that category. But 98.5 and 98.3, I mean, those are still phenomenal achievements by your members and by the plan design, by all of us.
Thank you, Mike.
Yep. I'm going to move on, if it's okay, to another report I added this month, but it has to deal with your financials, and it's regarding COVID and treatment claims. And there's a lot of detail there, but I'll just try to summarize it for you. There's two reports, actually. One says COVID-19 test, and the other one is going to be COVID-19 confirmed claimant analysis. And again, a lot of our clients are asking us what kind of financial impact is this having on our plan, on our members. So On the bottom right, if we concentrate on that column, and this is data for 9 months, going back from March through November. We look at where it says all, the column. Claimant, 257 people. And this is employees, spouse, kids, belly buttons. 257 went to be tested for COVID-19. There were claims that came out of that, so the tax administration, some other things, total of 642 claims, roughly about $60,000. So about $92 per claim, or about $230 per claim. That was paid by your claim. The antibody testing is to test to see if someone had COVID-19. And it would show up that there was a trace of it, and somebody had it. There were 12 claimants in that category, and 17 claims dollars, or 17 claims, and a per claim cost of $47, or per claimant of $66, for a total of $802. So roughly a little over $60,000 in testing costs for COVID. The rest is just a lot of detail, breaks down employees, spouse, kids. Roughly, the majority of that were employees, roughly I think 60 of the take it back, I'm ahead of myself. The next category here, the next report that talks confirmed claimants, we actually had 81 members that had COVID-19 confirmed. And of those, 64 in the far right column were employees, 11 were spouses, and 6 were dependents. And there were some higher costs associated with those. From a claim standpoint, if you go to the top of page 2, it summarizes those. At 1,256 claims from all of that, for a total of $273,826 that was paid. Roughly about $3,380 per claimant, or another way of looking at it, $218 per claim. So a total of 81 members that had that. I don't have any reference point to say that's high, that's low. That's just what it is on your claim. Any questions on that?
Mr. Hicks has a question.
Yeah, I guess in my ignorance or attempting to grasp this, could you help me explain on the very first one, the testing one, the first couple lines, when I said we had 257 claimants with 642 claims, how do we get 642 claims out of 257 claimants unless those individuals had multiple claims on themselves that they went in several times, or am I missing something?
No, it's a great question. So it's not just that there was, and then there was what took place when they were there. So yeah, there could have been multiple things besides a nose swab. It could have been some other physical testing to the member at that time. So and again, when the way COVID's been turning out, it seems like it's got multiple different effects on people. So you have fever, you have taste buds, you have multiple things. So what the other tests were running at the time, those would have been the additional claims. And I can see if we can get more detail on that. But so keep in mind, everything is in healthcare. I remember when we're in the hospital, if we get aspirin, that's a claim. Okay, it's a pharmacy claim. So every little thing is transparent, and identified. I don't know if that helps.
Yeah, it did, thank you.
No other questions from here. Anyone on WebEx have a question for Mike?
Mike, this is Brian Wilson, I have a question for you.
Yes.
Hey, I'm curious, how is the vaccine being covered? Is that going through health insurance? Is that being covered under federal government? How exactly is that rolling out?
Yeah, so what we're seeing right now and what we're being told, is that the vaccine itself will be at a no cost to your plan. However, the administration cost of that, the plan will incur a cost for it. So the where it's administered, the doctor's office, the hospital, wherever, those facilities will ultimately have some type of claim cost. It's not accepted from what we're seeing. Let me see, I haven't received the comment from our Blue Cross rep on that. So, just the vaccine, the administration will be covered by the plan. So, administration, again, the federal government will be covering the vaccine. We'll share more information as we receive updates about broader vaccine distribution and access. Initially, we anticipate that the cost of the vaccine will be paid by the government, Blue Cross Blue Shield, or the plan sponsor will cover administration of the vaccine as noted below. So self-funded plans, self-insured, must cover the COVID-19 vaccine and its administration as a preventive service with no cost share to the members at in-network and initially out-of-network also during the public health emergency. So, Ryan, a little more information, as I get it, I'll bring it next month. So far, I've not seen, the cost to administer that, I've seen one TPA, kind of suggest that the cost would be under $50. But again, it's clearly going to be based on what people have the administration done.
Okay, well, thanks.
Okay, Mike, we have a question from Tom Walsh.
Does that same thing apply to the retirees coverage?
Oh, yeah. You mean the Benestar plan or the?
Yeah, the Benestar, right.
65.
Right.
Yeah, the Benestar, it's a great question, Mr. Walsh. I don't want to assume anything, but I don't see why not, but I will get that validated. It should be, actually, again, if this is going to be classified as a United States Preventive Services Task Force preventive benefit, it would be mandated that it would be included. But again, I didn't ask that question, so I'll get that for you. Great one. Thank you.
Okay, no other questions from members present. Anyone on WebEx? Okay, anything else for the committee, Mike?
Yes, I owe you an update on the benefit claim audit from last time. And I received some, And again, I was suggesting that the company that we're dealing with had a way of doing the audit on a contingent basis. And I stand corrected on that. And at one time, they were doing that long ago. But the carriers frowned on that, basically, not allowing that type of contractual arrangement. So that price stands at the 21,000 from medical and 9,000 from pharmacy, roughly thereabouts. So we are back to the drawing board at researching some other companies for that service. Now again, that service, as a reminder, was looking backwards to see were claims done proper. And I got introduced and there was some interest in, instead of going backwards, because that's a year or two ago history, is there a method to go forward? That same company is introducing a model to do that. The carriers and the TPAs aren't accepting it too well yet. But that cost would be about $1,500 per month as it stands right now. Our biggest hurdle there is will carriers give them data each month? Contractually, they like to do audits once a year. So, so I have to put that on pause for you right now. I apologize, but hopefully for January, we can take a look at that again. In addition, one other item that we shared was forwarded to Melissa, I believe.
Yeah.
Melissa, was that shared with the committee?
No, I wasn't sure what we were doing with it or what you wanted to explain, so I can quickly make like a detail of that email, or I can give it to him after.
Yeah, I don't know what direction you need for that. It has to do with our wellness team. So Horton, as we expand, we've created another division of Horton. And we send out a communication to our clients to try to explain and be very more transparent in the process as we go forward in the area of wellness. So in the way our wellness team has worked in the past, again, we didn't charge any additional dollars for their services. It was built into our fee structure. And as we explained in our fee structure, again, we had a new one go in 2019 where we reduced our fees when we did the retiree program. We included wellness in there. And again, our wellness team is at your disposal to help build the wellness efforts for the county to improve your employees' health status, to help them individually and also to help lower claims. And they do that both medical side, behavioral health side, et cetera. Well, how that wellness team potentially also got paid was through the override through some of the services that they provided. And it's a term that again has some fuzziness to it that we wanted to be more transparent on. So last year, in the process, the screening companies paid Horton an override, not a commission. They said it's not what we called it at that time. We had no control of it. An override on that, and then there was an override on the EAP. In total, it amounted to about $2,200 last year. We want to go forward, call that instead of an override. We want to call that out as a commission in our contracts and identify where that might actually take place. So as we move forward with wellness, right now we're using e-health for screenings. There are other more advanced screening companies as we start adopting greater interest in wellness and proving its value. There's a lot of analytics that come into it, gaps in care, addressing gaps in care and doing reach outs and things like that. And those start having cost to it, so, and a different look. So what Morton has done is, we created another division that actually oversees our wellness and our safety teams and some of our commercial claims. So we're looking at an integrated approach down the road where we could offer more to our clients. When we get into that space, it's got to have some clarity in how it gets paid. So all we're asking with this amendment to our current contract is not to change our rates. Nothing, no price is going to change. The screening company's prices isn't going to change based on a Horton commission or anything like that. That's already there. We just want to point out, hey, we're going to call that a commission going forward and include that in our transparency to you. Just so we have a clear understanding as we move forward, that's all.
Okay, any questions on that for Mike?
Ally, just ask him when we need to have the
So
signed.
Okay. Just one moment, Mike.
When does he want the signed document back? Because I have it printed, it just needs to be signed.
Okay. Melissa had the question, when would you need the signed document back?
I'm sorry.
Melissa would like to know when you would need the signed and approved document back.
I think we dated it December 19th. That's fluid. Whatever's convenient within, we're looking forward to go going forward for 2020. So whenever I don't exactly know the process that has to go through on your end. Et cetera.
I think if you just accept it because it's not like he said, there's no pay related to it, there's no cost change. And if you approve it, then I think most of the documents that we have, the board chairman signs, so I can just get Don to sign it after you say that you're accepting it. So it's just repeating, and I have a copy, I can make a copy for you. I didn't really know how he was gonna explain it today. It's really just amending and saying that they're calling the wording different than what they were calling it before about how they're getting their dollars from those other sources. They're calling it a commission now. And that's not from us, that's from their sources that they use that pay them right now for the wellness components. So,
My thoughts on the item is there's no change to the actual contract or cost. And it is not an agenda item. I would say that we can just have a motion to accept the changes and then forward it to the board chairman for signature. Don, do you have any opinion on that?
Well, my thoughts are, if it's not an agenda item, it should be done later. But part of the issue is you don't have a quorum, and I'm part of the quorum.
Well, we do have a quorum as Mr. Dodds and Hodger are attending on WebEx. We just don't have a quorum present to approve the bills because they actually have to sign them.
Okay. Yeah, that'd be fine. I don't see, there's really no monetary changes.
yeah.
Right.
Mhm.
Okay, we go into the action portion of the meeting. We will accept those, have a motion to accept those changes. Any
We don't really
questions
have
from,
anything else.
any other questions
All they
from
do
Mike?
is sign it. Right. I think can't you have your meeting minutes that they reviewed it, and they were fine with them signing it, that there's no changes?
The relevant to it, because I don't want to think that we're, and it's different, all the work that we just did with Lavaco and selling that, anything that's through the carrier itself, through Blue Cross, there's no override there, there's no commissions in there. We're just doing that for our self-fees. So, and not to rehash all this, but I just wanted to kind of give you kind of a drawing line. The drawing line comes in for the outside vendors outside of the norm. That's what it boils down to. So I thank you all for your consideration of that. Sorry to be confusing.
I will note it in the minutes, that we are gonna,
Sign
discuss
for
it and we'll just have it signed.
Okay, for those who could not hear Ms. Zeal's comment, motion is not required. It'll just be noted that there is a change to the agreement with no additional cost to the county. Okay, Mike,
Thoughts
any?
on that, Mr. Walker, Mr. Hicks?
No.
Thank you. Any questions, any other questions?
Any questions or comments for either Mike or Beth? Hey, Mike, anything else for the committee?
Yeah, thanks, Chairman. Thanks, everybody. And again, enjoy the holidays, remaining holidays. Next month, we plan on doing our formal year-end report. We have a PowerPoint to present, giving the historical view, and then also tee up any strategies that we're, seeing will be coming down the road for our healthcare clients. And so, I'll work to get that on the agenda, Melissa.
Okay, if you just want to keep in touch with Melissa on that, so we can get the agenda out. The next meeting will be Thursday, January 28th at 9:30.
Very good.
Okay, anything else? The minutes from the last meeting have been sent out, because most of the people are not online today and were not present. Mr. Dose, would you make the motion to approve the November meeting minutes?
Alan, I would love to.
Okay, we have a motion by Mr. Dose. Mr. Walsh, will you second?
Yes.
And a second by Mr. Walsh. All in favor?
Aye.
All present, aye. Against? Motion carries. Okay, Mr. Walsh, Mr. Hicks, have you seen the bills?
Yes,
Okay, Mr. Hicks, will you make a motion to approve the bills?
I'll make that motion.
Motion by Mr. Hicks, second by Mr. Walsh. All in favor?
Aye.
Opposed? Bills are paid. If there is nothing else for the committee or the Horton Group, I'd ask for a motion to adjourn.
Wait, we need a motion to place the Horton report on final.
Thank you. We need a motion to accept and place the Horton Group report on file.
So moved.
Okay, motion by Mr. Walsh. Do I have a second?
Mr. Chairman, I'll make the second.
Okay, we have a second by Mr. Dose. All in favor?
Aye.
All ayes, no opposition. The minutes are, the report is approved and accepted and placed on file. Now, if I may have a motion to adjourn.
I'll make that motion.
Motion by Mr. Hicks. Do I have a second?
Second.
Second by Mr. Walsh. All in favor?
Aye.
Aye.
Opposed? Meeting is adjourned at 11:42. Thank you, everybody. Have a great Christmas.
Take care.
Thank you, bye-bye.